Okay, everybody, let's get started. Thank you so much for joining us today. Today is we're going to be doing a Grand Rounds presentation, Barton Health System's Grand Rounds, and this is presented by Tahoe Emergency Physicians. Thank you, everybody, for joining. Okay, so today we're going to talk about adult, and that's important, adult ACLS, and we're going to talk a little bit about the 2015 AHA guidelines update for CPR and emergency cardiovascular care. All right, so this is a big document. As everybody's aware, every 5 years the American Heart Association sort of updates their guideline, kind of appraises us of the current literature on the nuances of cardiac arrest care and the care for acute coronary syndromes, among other topics. And we're used to the AHA coming out every 5 years and giving us an update, and sometimes it seems a little bit mundane. There's atropine is in, atropine is out, what's the dose? Is it high dose epi? Is it low dose epi? Is it stack shocks? Is it lidocaine or amiodarone? So it gets a little bit mundane, and sometimes we tend to blow this off. But I do think that this is a very important document, and so we're going to go over some of the key features that apply to some of the pit docs who are actually looking after these patients. And we're going to split it into two parts. Part one, we're going to talk about cardiac arrest, and I'm going to present this part. We're going to talk about intra-arrest care and a little bit about post-arrest care. And then Dr. McLaughlin's going to come up in part two and talk about acute coronary syndromes and some of the important updates there. So I love this little cartoon about a heart attack or cardiac arrest. Do you know the difference? It's a little confusing sometimes, I suppose. Okay, so now, before we dive into talking about cardiac arrest, I do want to address the gorilla in the room, which is what exactly are we trying to accomplish? Because if you're like me, at some points in my career, a couple of points already actually, I've become somewhat nihilistic about cardiac arrest, and this may be after seeing a series of consecutive, PEA asystolic arrests transferred from the nursing home or up in the intensive care units, or, unexpected deaths, and they come in with chest compressions, and you're not very hopeful from the get-go, and they tend to be having very bad outcomes, and you're talking to the family. It's a very horrible experience for everybody. And we tend to get a little bit nihilistic off and on. So I think it's really important to back up and take a little bird's eye view of what's going on with the AHA and the research on cardiac arrest and some of the resuscitation research. Okay, so we're going to just kind of take 1 minute here to do a bird's eye view. All right. So here we are, 2015, and we're going to talk about some updates today. But let's go back to 2005, because I think 2005 marks, in some ways, the beginning of an entire new era of cardiac resuscitation research. And we are developing giant research consortiums like the ROC group, and which includes hundreds of EMS systems, multiple facilities, giant trial registries, and we're doing prospective studies. RCTs are being done, large observational studies. So the sophistication of the research has changed a lot. So I think it's really important to kind of take a look at what's been going on in the last 10 years. So in 2005, the overview was, hey, there's something to the chest compressions, the quality of chest compressions, and the minimizing the interruptions in chest compressions. And so what happened in 2005 is they recognized that we want to minimize interruptions in chest compressions. They took away stack shocks, which was it resulted in a lot of interruptions in chest compressions where you would be delivering multiple defibrillations, and they recognized that bystander CPR was very important in terms of outcomes, and also that bystander CPR in modern developed countries, the rates of bystander CPR were abysmal. So that was kind of the focus of 2005. And then subsequently there was some data that came out of experimental data that came out of pigs and dogs and even humans later that showed that when you take your hands off the chest, the cardiac output drops precipitously, and more importantly, the chance of ROSC drops precipitously. So they found that there was an association with interruptions in chest compression in animal models and really abysmal rates of ROSC. So they did some more studies and concluded that there was something to minimally interrupted chest compression, something to early bystander CPR, high quality CPR, and recognized the importance of the quality of chest compressions. And in 2010, CCR, or cardiocerebral resuscitation, this is a basically minimally interrupted chest compressions approach to cardiac arrest, and that includes pulse checks and such, and really minimizing perishock pauses. And they actually published some data that showed that the survival of patients who were receiving cardiocerebral resuscitation, uninterrupted chest compressions, versus 2005 ACLS guidelines actually had an improved survival with some statistically and clinically significant numbers. And so you started to hear about CCR and chest compression only resuscitation, and this is when people start talking about hands-on shocks and do everything you can to minimize chest compression interruptions. And they also focused in 2010 on the optimization of quality of chest compressions, depth, rate, using metronomes, using feedback from defibrillators. In 2010, the EMS systems went to these defibrillators that had continuous feedback in terms of rate, depth, etc. And they put a de-emphasis on intubation because that was resulting in interruptions in chest compressions. Okay, so that's 2010. And then in 2015, the research essentially in that time frame has recognized the importance of CCR in terms of cardiocerebral resuscitations, uninterrupted chest compressions, aggressive chest compressions, forward flow. And then now we're looking at how do we actually quantify some of those measures? How do we quantify the quality of chest compressions? How do we quantify the quality of the resuscitation? And then on top of that was the end package is getting people to PCI, ECMO, and cooling, targeted temperature management. Okay, that's 2015. And so the future, of course, is going to be goal-directed therapy for resuscitation. This is going to be vasopressor and epi-guided dosing by transcranial perfusions and infrared spectrometry. And there's going to be use of hemodynamic monitoring that's going to guide our therapy in patients who in dosing of vasopressors and what drugs to use, and more importantly, like who to take to ECMO and ECLS and ECPR that's the next step. Okay, so let's just kind of look at some numbers here. So survival, all comers. Cardiac arrest presenting to an acute care facility in 2005 was 5.7%. All comers, all rhythms. And then in 2015, it's 11% in the United States. Okay, so that's a substantial improvement in all comers survival. These are patients, by the way, that are walking out of the hospital. These are survival to discharge. Okay, so now let's look at witnessed shockable ventricular fibrillation, pulseless VTAC arrests. In 2005, there were 15% survival. 2015, 31%, so double survival. Okay, so let's look at places like Seattle. Now, Seattle has the highest survivals in the world. 2005, 35%. 2015, near 50%. Near 50% who drop dead in the street in Seattle with VF as their first rhythm, who have a witnessed VF arrest. 1 in 2 of them are walking out of the hospital. Okay, so that's where we're at. We are really at a place in time in which we are making some incredible headway in survivals, and with neurologic survivals. Meaningful neurologic outcomes are really starting to rise. So I think it's important to really recognize that as we look at some of these changes and start to incorporate this stuff into our practice. Okay, so that was the baseline. That's the overview. That's where we want to start from. So, chest compressions, chest compressions, chest compressions. All right, ABCs have become CAB. In 2005, we discussed it. This is a circulation, then airway breathing. And in 2010, CPR became cardiocerebral resuscitation, chest compressions only resuscitation, and we've seen dramatic improvement in survivals. Okay, so chest compressions are the key fundamental take-home from 2015. And in 2015, the question and the goal is, there are two things basically. One, how do we minimize interruptions? How do we practically minimize interruptions in chest compressions? Because it's hard when you're the team leader and you're a single operator in a small facility like this. It's hard to run a resuscitation room and focus so much on the interruptions. You have to be a Hawkeye. And the other thing is optimizing the quality of chest compressions. So let's talk about a couple of strategies. If indeed this is the most important aspect of early cardiac arrest care, let's talk about some strategies to do this. So one, keep pulse checks to a bare minimum. The guidelines recommend Q2 minute pulse checks, and we've been doing this for years, but the reality is that you really need to focus on keeping pulse checks really quick, because you want to minimize that interruption, and that is a place where a lot of interruptions occur. Now, one way to do this is you just stop chest compressions, and you look at the monitor and you look for an organized rhythm. If you don't see an organized rhythm, then just get back on the chest. There are many ways to do this, including having a single operator devoted to being on the groin and feeling the pulse during compressions, so that you can stop really quickly, take a look at the monitor, and if you do not see VF and you do not see any change in your rhythm or any organized rhythm, then just get right back on the chest. And if you do see something that may be sinus or maybe perfusing, then that would be the time to take an extra second to look at the pulse. There are other ways to do pulse checks and keep them to the bare minimum, but really focusing on your end tidal CO2 and the monitor, as opposed to really stopping everything you're doing and taking a formal carotid or femoral pulse check. Just keep those really quick, less than 10 seconds for sure. The other thing is, the other kind of emphasis that they're making is deferring tracheal intubation. Now, this is something that's pretty well established. I mean, you're seeing people come in from the field with Kings and sometimes with just BVM, and they're not really taking much time in the field to intubate these patients, because they're really focusing on putting the airway on the back burner, at least early in cardiac arrest, so that you don't interrupt chest compressions for tracheal intubation. You cannot interrupt chest compressions for intubation. Now, some people are really using point-of-care ultrasound also for pulse checks and to minimizing interruptions by doing a number of things. People are using ultrasound for all sorts of stuff in chest compression. We'll talk about that briefly. Some people will look in the subxiphoid area at the heart, and then you take the compressor stops for a second, and they look at the heart and see if it's contractile or hypokinetic or standstill. Some people will put it in the groin or on the carotid and look at the vessels, because if you can see the femoral vein and artery during compressions, then you can stop compressions very briefly and see if the artery is pulsatile, for example. That's one way people are using it. And it's not really clear how ultrasound is helpful, but this is one way to minimize your interruptions in chest compressions. There are even people talking about Doppler flow on the carotid during resuscitation, and that's another way people are using it. Now, the other thing is end tidal CO2, and I think that this is an important thing. We'll talk about this in a minute, sort of specific to end tidal, but this is another way you can really minimize interruptions by just focusing on your end tidal as a gauge of the quality of your CPR and your resuscitation. Another strategy for minimizing interruptions in chest compression is to minimize the perishock pause. This is a time when a lot of delays, a lot of interruptions in chest compression can occur when you look at the monitor. Say you're doing chest compressions and you're doing them perfectly and vigilant and optimal depth and rate, and then you do a quick stop and there's VF, and then it's charge the machine and deliver a defib, and then you wait some more and look at the rhythm and then take a pulse check, and there can be quite delays. And really focusing on the perishock area as a way to minimize interruptions is very effective, and the AHA is emphasizing on this. So in the pre-shock phase, you're doing a round of CPR, and you do a stop for less than 10 seconds, and you look at the monitor and you see VF. Get right back on the chest and continue compressions for another 15 seconds while the machine charges, and then as the machine charges, you count down 3, 2, 1, hands off, deliver the defibrillation, and then get right back on the chest. and then give compressions for 10 or 15 seconds again, and then look at the monitor and take a brief pause, look at the monitor and see where you're at, and take a pulse check at that time, or look at your end-tidal CO2. There are ways to minimize the pre and post-shock pauses. Okay, the next most important message today is optimizing the quality of compressions. And how do we do this? I mean, practically speaking, how do we do this? The AHA is saying that the optimal depth is about 5 to 6 centimeters, just over 2 inches, and the optimal rate is 100 to 120. These are both updates from 2010, but they're nominal. Essentially, they've found in some observational data that going too deep and too fast can be harmful, and they're a little concerned about that, and so they kind of put some upper end limits, but whatever. But how do you optimize and monitor and quantify the quality of your chest compressions? So they're offering the research on resuscitation is offering a couple of solutions at this time, are preliminary anyway, and one is arterial lines, of course, are ideal probably at this time in terms of targeting a diastolic blood pressure of 40 millimeters mercury during resuscitation as both a surrogate of your coronary perfusion pressures, but also maybe even like a goal-directed type of therapy for vasopressor administration. A-lines are very helpful, but you know what? They're not happening. They're not pragmatic in a single operator shop, and you don't have the hands to put them in. So another option is end-tidal CO2. End-tidal CO2 is very effective, and the data is not there, the outcome data, but there's a lot of information available about how to interpret end-tidal CO2 and how to use end-tidal CO2 as a target, as a gauge of the quality of your chest compressions and your resuscitation, and even targeting a number, 12, 15, 17, 20, trying to get it higher as you're doing your compressions is being talked about, and we're going to talk about that briefly here in a minute. Okay, so now that we've kind of done the overview and we get the final gist, that's pretty much the gist of the AHA is what we just talked about. Chest compressions, and then we'll talk about post-arrest care real quick. In general, it may be reasonable to consider. That's all you really need to know from the 2015 update. Anything you want to do or not do, it may be reasonable. Okay, so let's sort of bang through a couple of these key features so that we can kind of get to the end of this. One thing, so they do mention this, and we're going to kind of continue on this little tangent in a way, but they do mention monitoring physiologic parameters during CPR. This is a big message in 2015, is quantifying our resuscitation in some way using physiologic monitoring. And this can be in the form of quantitative waveform capnography, which is by far the most accessible for most. Arterial relaxation, diastolic blood pressures, arterial pressure monitoring with A-lines, and like I said, there's some human data on targeting a diastolic blood pressure, central venous oxygen saturation monitoring. And these guys are even going so far as to saying, using these to guide vasopressor therapy and detect ROSC are the way to go. So let's talk about end-tidal CO2, because end-tidal CO2 is kind of at this time the most applicable to us. You can't put A-lines in people. You're not going to be doing SVO2 monitoring. We don't have infrared transcranial perfusion monitoring. So end-tidal CO2 is actually something that I think is important, and in my mind is a must, in my opinion, and in the minds of the AHA is also a mandated form of monitoring cerebral resuscitation during cardiac arrest. So what are we looking for? How are we using capnography? Number one, confirmation of tracheal intubation. This is a standard. This is mandated for EMS, has been for a long time. Looking at evidence of waveform capnography on an intubated patient is the standard for confirmation. Now, a lot of us are if you see the tube pass the cords, then that's also confirmation. So there's that, and then number two is monitoring the quality of CPR, and we just talked about this, and it's important to kind of recognize briefly what is end-tidal CO2. It's not your PCO2. It's not a ventilatory monitor. It doesn't really give you an indication of alveolar minute ventilation. It's a sort of a combination of cardiac output and a little bit of information about your PCO2. The end-tidal CO2 gap between your PCO2 is mitigated by a lot of things, including VQ mismatching, especially in the form of dead space ventilation. And in a patient who's in cardiac arrest or shock, the number that you're looking at is much more of a measure of pulmonary blood flow and like cardiac output. So if you have a cardiac output of 0, your end tidal CO2 is going to be 0. And so when you start pushing on the chest and you're improving pulmonary blood flows, then your end tidal CO2 will go up. So as you're doing compression, it's a way of looking at the quality of your CPR. If the number is 10, try to get it to 15, and so on. And you may have to go deeper and faster to do that. But that's how that works. You're looking at, so it's a surrogate cardiac output monitor in terms of pulmonary blood flow anyway. It may very well be an oscillating column of blood, but the idea is that you're getting forward flow. Number 3 is detecting ROSC. So along those same physiologic lines, if you all of a sudden get a spike to your end tidal CO2 to 30 or something, you can anticipate that you have a perfusing rhythm, or you may have had a change in your rhythm, or you at least have some improved cardiac output. And then 4th is terminating resuscitation efforts. If you fail to achieve a end tidal CO2 greater than 10 after a prolonged resuscitation during your CPR in intubated patients, you have very, very poor prognosis, and you can use that as a objective measure of terminating your resuscitation efforts. Okay, so now we're going to start moving through some minor stuff. Okay, so oxygen dosing during CPR, they say use the maximal feasible oxygen during CPR, maximal FiO2. After ROSC, titrate down. Hyperoxia has been shown to be bad in post-arrest patients and many other patients, including traumatic brain injuries. So maximal oxygen during resuscitation, titrate down after ROSC. Ultrasound during cardiac arrest. Now, we talked about this briefly in terms of using it as a gauge of CPR and even for detecting ROSC. But they do say, and I do emphasize here, a lot of people are using ultrasound for different things, including looking at the heart during pulse checks, and it can result in substantial pauses in CPR. And so these guys are saying, yeah, if you're good at it, you're facile, you know what you're looking for, fine. It definitely plays a role, but make sure that it does not interfere with standard cardiac arrest treatment, such as CPR. Advanced airway placement. This is a very interesting one, and I think important, and it kind of goes back to what we were saying in the overview about deferring endotracheal intubation during the early phases of cardiac arrest as a way of minimizing interruptions in chest compression. Also, hyperventilation can result in increased thoracic pressures and decreased venous return, which has also in observational studies shown to be bad. So they're saying defer the airway. You can do a bag mask device or an advanced airway such as a supraglottic device. A supraglottic device such as a King or LMA is probably superior because it does provide some aspiration protection, but keep ventilation to a minimum. Clinical assessment of tracheal tube placement. We talked about this, continuous waveform capnography. That's what they're saying, is waveform capnography, confirmation of intubation. They also say you can use ultrasound here, but that's something I don't have any experience with. Antiarrhythmic drugs during CPR, and they're saying that if you have shock-resistant VF or pulseless VTAC, that amiodarone is appropriate, and they're saying amiodarone. It's a long story. Basically, antiarrhythmics have had no impact on meaningful outcomes such as walking out of the hospital neurologically intact, but they do improve ROSC in the trials that have been done, which have not been able to recruit enough patients to speak to survival. So their outcome is typically survival to admission. Now, they die at the same rate in the ICU, so one camp says, well, why are we even giving antiarrhythmics? Because all they're doing is improving ROSC, but everybody dies in the ICU the same. And the other camp says, well, your first goal is to get ROSC, and if you don't get ROSC, then there's no hope. So it's reasonable to give antiarrhythmic drugs, but they're saying in refractory arrest. So vasopressors, standard, epinephrine, there's no changes there. Standard dose, 1 milligram every 3 to 5 minutes. They're also saying that vasopressin has no role in cardiac arrest and have removed it from the adult cardiac arrest algorithm. That's basically based on studies that have shown that the addition to vasopressin to epinephrine has not shown any improvement in meaningful outcomes. Okay, so early epi, standard dosing, it does improve ROSC. Vasopressin is out. Okay, steroids in cardiac arrest. This is a little bit of an interesting topic. We don't have time to get into too much, but the there was some studies in Greece that showed in hospital cardiac arrest, the combination of vasopressin, epinephrine, and methylprednisolone resulted in significantly improved outcomes, primary endpoints of survival to discharge, and with a positive neurologic score in a randomized controlled study. So the AHA is saying for inpatients in hospital cardiac arrest, this is reasonable. And for me, I could talk about this a lot. I mean, the study was done in Greece, and basically it was really well done. They get 20 units of vaso and a milligram of epi every cycle, and during the first cycle, they actually got 40 milligrams of IV solumedrol, and the control group got some placebos. And the VSE group, or the steroid group, basically had increased ROSC and improved outcomes in survival with neurologically positive scores, with a number needed to treat of like 11. So it's a pretty interesting study. I think if I respond to in-hospital cardiac arrest, I will probably be doing this. Prognostication, they're saying use end-tidal CO2 here in combination with other factors. So not in isolation. You can't just look at the end-tidal CO2 and call the code. You really have to kind of think about other things that are going on. But if you have an end-tidal CO2 of less than 10 or 10 or less after 20 minutes, that is associated with horrible outcomes, and that can definitely be a component of your decision to terminate resuscitation efforts. Now, this is actually kind of a neat part of 2015, is they're starting to hone in on prognostication, which I like. Now, some of you have heard, I'm sure most of you have heard about this sort of like novel approach to PEA. You get a PEA patient, you look at the ECG or the EKG, and you look at the QRS. Is it narrow or is it wide? And that sends you down two different sort of algorithms. If you have a narrow QRS, you're thinking that there may be RV collapse, or there may be right ventricular outflow tract obstruction, such as a pulmonary embolus, a tamponade, or tension pneumothorax. This might lead you to throwing the ultrasound on, and or doing things like finger thoracostomies, or even thrombolysis for a PE. Now, if your QRS is wide, you're thinking more metabolic and ischemic, and you might start giving things like bicarbonate and calcium, etc. And, I don't know. This is not being endorsed by the AHA. This has not been associated with any sort of outcomes if using this approach, and it's not clear how to use this approach in terms of your decision making. I think a lot of your decisions are still going to be based on clinical assessment and bedside stuff in history. But it is worth looking at the QRS and thinking about it in terms. It's a good way to kind of frame your thoughts when approaching PEA. I mean, H's and T's are awful. Okay, so now we have just a couple minutes to go through the post-arrest care, and this is going to be fast because it's pretty simple for us, really. It's a critically ill patient. It's a rodeo. These patients are super unstable, and the foundation of post-arrest care is just hemodynamic optimization, good critical care. Keep your MAP above 65. TTM and hypothermia, very important. Lung protective ventilation. And then PCI. PCI is a hugely important part of this package. In the 2015 AHA, they actually give us some guidance on who needs to go to PCI right now versus who needs to go PCI in a while. Okay, so hemodynamic goals. They're saying MAP greater than 65. There's a long backstory here. There's been some observational studies that have shown higher MAPs are better for cardiac arrest. They're saying MAP greater than 65. Targeted temperature managing. Now, this is important to remember because the TTM trial came out in 2013, and it showed no difference between 32 and 36 degrees. And some people out there have interpreted that as, cooling doesn't work. But both of those groups were intervention, and both of those groups had active cooling. And hyperthermia is bad, and cooling is absolutely important. The AHA is saying that the intensivist can choose between 32 and 36 degrees. But we need to initiate cooling during arrest. And I know that a lot of people like to give cold IV fluids, and I'm one of them. But remember, there was a study in Seattle in the EMS setting. They were giving 2 liters of cold saline, and it resulted in increased CHF, increased cardiogenic shock. There's more data that's coming out on that topic that have shown, it's not published to my knowledge, I think out of Canada, that they're giving like 500 cc's to 750 cc's, like pre-hospital cooling, and they're not seeing that. So just cooled IV fluids are okay, but do not give large volumes. Ventilation oxygenation, we talked about this. Normal CO2, normal oxygen. While you're doing CPR, they're saying give maximal oxygen, but after you get ROSC, it's time to get that ABG and titrate your O2 down to a pulse ox of 94 or a PO2 of 100. You really want to have normoxia. Okay, so this is the last topic. This is probably the most important. Who gets PCI following cardiac arrest? This is a huge topic. There has been a lot of discussion about this, and there have been fairly large observational databases that have shown that, all comers with cardiac arrest have improved outcomes with PCI emergently. 30% of people have lesions that are amenable to stents. 70% of out-of-hospital cardiac arrests are related to cardiac causes. So anyway, we're honing in on who benefits from PCI, and the AHA is coming out and they're saying obviously the patient who has an ST elevation on their EKG. Either pre or post arrest, those patients need to go emergently to cath. They just had a STEMI and they had an arrest, and it's commonly VFib. So you can identify those patients if they have a VF arrest. If their first rhythm is VF in the field, then you just should be thinking that's a STEMI. They're also saying that emergency angiography should be considered for patients who are hemodynamically unstable or electrically unstable, recurrent, especially recurrent VF. And they're saying patients who don't have STEMIs, who have a super high probability of having a lesion, then they should go to cath too. And they give us some guidance on that by giving, and they talk, about these Utstein factors, and we talked about, and this is one of the most important things about the 2015 sort of evolution. Everything about cardiac arrest is about favorable and unfavorable characteristics and risk stratification. Patients come in with unfavorable characteristics, like you don't even want to start resuscitating them. You just call the code. Patients who come in with favorable factors, if you're in Seattle and you have a witnessed VF arrest with early CPR in the field and early defib, you have a 50% chance of walking out of the hospital. So recognizing these patients are the most important update to 2015 and deciding who to be super aggressive with, including PCI and ECMO, frankly, and ECLS. Favorable factors are witnessed bystander CPR early, initial rhythm VF, early defibrillation, ROSC in the field, recurrent VF with recurrent ROSC, short downtimes, or a STEMI on your 12 lead. Those patients need to go to cath. Unfavorable characteristics are everything you would think. Non-VF arrest, asystole, PEA, elderly, no ROSC, long downtime, and then things like acidosis and lactic acidosis, things that are reflective of prolonged resuscitation. So essentially there's an algorithm here. You have a patient who comes in with cardiac arrest and they have a STEMI on their pre-arrest, or they get ROSC and they have a STEMI. Those patients need to go to cath. Okay, I mean, that one's easy. And then you have the patient who comes in who does not have a STEMI. Which of those patients need to go to cath? And this is basically, you assess for unfavorable resuscitation features, pick up the phone and call the cardiologist and have a discussion with them, and then look at things like, was a witness? Was it VF? Was there early CPR? Is this patient having a recurrent arrest? If patients are having VF and recurrent VF, they're just begging for a cath lab, and you should do everything you can to keep them alive to get them to cath. But everyone else, it's kind of a discussion. So they do chime in on that, and that's very helpful. So that's the gist of arrest. And I know we went a little bit over time, so I'm just going to cut here, and we're going to let Dr. McLaughlin blow you away with some acute coronary syndrome knowledge.